Welcome to the fourth session. And now that you understand what latent TB infection is, we now want to look at a broad view, especially around some of the evidence around the management and treatment of latent TB infection. So what is latent TB infection? Basically, not everyone who is infected with TB develops TB disease immediately. Some people would go on to have this latent dormant form of TB, which is non-replicating for years, but it can be reactivated over time, especially if there is changes in the competency of their immune system. This form of TB is called latent TB infection. And the theory around it is that if someone has latent TB infection and we manage to identify them and treat the latent TB infection in time, their risk of developing TB later on is actually significantly reduced. So TB preventative treatment is therefore the use of one or more of the TB drugs. So traditionally in South Africa, we used INH only for longer durations. Like at some point we were giving it for 36 months, but the current guideline says INH for 12 months. In today's world, we now want to add, rifamycins, where you can give rifampicin on its own or with INH, or the combination of rifampicin and INH. And these TB preventative therapies would be given to individuals who have latent TB infections with an aim to prevent the progression of latent TB infection to active disease. Treatment of latent TB infection will lead to the overall reduction in the case burden of TB in a country like ours, South Africa, the burden on the health system, and then the reductions in overall TB-related mortality, but also there would be cost savings as part of this program. So if you look at some evidence, especially, previously we used to have recommendations that a tuberculin skin test must be done before TB preventative therapy can be considered. In this instance, they looked at what is the evidence and what is the relative risk of developing TB, right? When you give TB preventative therapy to people who are living with HIV and AIDS who have a TST result that is positive. So it means we identified a high risk group. We then went on to test to specifically identify those who have a TB infection, latent TB infection. And then we said we won't give some TPT and we would give a certain group TPT, right? So it's very clear here that if you identify people who have latent TB infection and you provide them with TB preventative therapy, you get a 64% reduction in new cases, or you reduce their risk of getting TB, by up to 64%. So that is very significant, and we should not necessarily undermine the TST. We should only probably summarize from this specific slide that the greatest impact of TB preventative therapy is on high-risk populations who have a positive TST result. Now, in our setting, TST has a lot of challenges, whether it's the supply management of the actual tuberculin proteins or needles that need to be used to inject high-risk groups. The other issue is the interpretation of this TST results. Once you have injected it, people need to come back in 48 to 72 hours. Sometimes patients don't come back. When they do come back, the interpretation relies on the health worker's eyes and the ability to do an accurate measurement. So it has been a bit of an operational challenge, and probably led to the limited access to TB preventative therapy, even for patients who would have benefited the most from this treatment. So as a follow-up, studies started to look at, is there a benefit if we opt to identify a high-risk population, for example, people living with HIV and AIDS, and we do not look at the TST status. So we do not go on to try and diagnose TB exposure or latent infection, but we provide TB preventative therapy, irrespective of whether we have TST results or not. And you can see there was so there is significant benefit even when you take that approach, reducing the risk of developing active TB by up to 33%. So hence the current guidelines in South Africa recommend that we should provide TB preventative therapy irrespective of the TST results for our high-risk populations, specifically looking at people living with HIV and AIDS. So one of the key barriers, in scaling and implementing TB preventative therapy, it's healthcare workers, mostly my colleagues, doctors, who have a view, perception that if we rapidly scale up access to drugs like INH and rifampicin for the purpose of TB prevention, that we would end up with a large number of multi-drug resistant TB cases. This is a meta-analysis of a number of studies, and there is generally consensus that there is no association between a patient who came in, was screened for TB, they had no symptoms, started on TB preventative therapy. There's no association between that kind of an approach and the emergence of drug resistance. And you would see from the World Health Organization, there is a strong recommendation that providing TB preventative therapy to people living with HIV and AIDS does not increase the risk of developing TB resistance. Actually, if you go in depth in some of these studies, you would find that in some of the studies, patients who took the placebo, not necessarily the INH, you'll find that there was even a higher number of cases with TB resistance in that group. So it means the predictor of resistance is whether the person had been exposed to a resistant TB in the environment before starting any treatment, whether placebo or INH. So there's no direct association between taking TB preventative therapy in patients who have been screened and their TB screening outcome was negative. So that is very important. And it's important to know that we have to continue to screen patients on TB preventative therapy at each contact. As soon as we identify that they might have symptoms or active TB, we need to probably interrupt TB preventative therapy and investigate those patients for TB. The other reason why these patients have a lower risk of resistance is because, remember, latent TB, the TB these patients would have is a dormant, non-dividing. If it is dividing, it is slowly dividing, versus inactive TB, where the bacilli are rapidly dividing and patients are spreading the TB. So the risk of developing resistance in this context is quite low and should not be a key reason factor for limiting access to TB preventative therapy. Our goal is to end TB. That is the ultimate goal, is to end TB. And we believe that it's actually possible. So if you look at this graphical presentation, it shows that if we only focus on mitigating risk factors, for example, just dealing with HIV and neglecting TB, or even just saying no, we would only implement prevention interventions, or we only focus on treating TB cases, that are symptomatic and active, we might not get far, right? And I think the key message is that for us to reduce the number of cases, we have to do everything in combination. This would be a multiple intervention combination treatment, where both active and latent TB have to be treated. So we have to identify patients who are at risk of latent TB infection or who have it, and we have to treat it. But also make sure that every single case of a symptomatic suspected TB case is actually timely identified, screened, diagnosed, and treated. So treating latent TB infection would have a positive effect in terms of reducing the TB burden and supporting us as a country to achieve the end TB goals and strategies. Look at deaths, right? If you want to reduce TB deaths, it's almost impossible to do it without implementing an effective TB prevention program that's going to focus on latent TB. So we have to treat active cases, latent TB, institute prevention mechanisms, whether policies, environmental controls, and PPEs as needed, mitigate risk factors like diabetes, HIV, and so on. But it is the combination effort, not prioritizing one of these, but it is the combination effort that would profoundly reduce the number of TB deaths in our country. Right, so that was just a summary to say, what is this latent TB infection? What is TB preventative therapy? Yes, it is true that the impact of TB preventative therapy is high for patients who have a positive TST skin test, but we also have significant reductions in the risk of TB for patients who are at risk with or without a TST result. So our policy guidelines therefore recommend giving TPT to all patients, irrespective, to all at-risk patients living with HIV and AIDS, irrespective of the TST results. There is no evidence that giving either of the regimens as part of TPT increases the risk of resistance. And we believe that in combination with all the other interventions, latent TB infection gives us an opportunity to end TB in the next few years. Thank you very much for your time.